I would like to request Dr. Richard Moser, who is a professor of surgery and radiation oncology at Department of Neurological Surgery in University of Massachusetts, attending neurosurgeon, UMass Memorial Medical Center, University of Massachusetts in USA, founder and medical director of the neurosurgery program for Solidarity Bridge, an NGO which advances healthcare and surgical specialty capacity in Bolivia and surrounding regions. He was awarded Top Doctor Award for 5 years and was awarded the Albert Nelson Lifetime Achievement Award in 2018. Richard was here last year also. He's a good friend, a good human being. Nice to be with you, Richard. May I ask you to start your lecture, please?
Thank you very much. I'm certainly honored to be here. And I must tell you, you know you're in trouble if the speaker apologizes for his talk even before he has given it. I enjoyed the interactive sessions of earlier this morning, and I wish I could do this over again, but we will go ahead with what I have brought with me. The first thing I want to ask is, could somebody please lend me their wall so that I can take it back with me and get our government running again? After that, we will go on to the next step, but that is my only political statement. The important thing is that we're treating individuals, even though when I was asked at a guidelines conference to speak about a traumatic brain injury, and I took that quite literally, which you will soon see, we are actually treating patients. So no matter what we talk about in the guidelines, it really does not tell us how we're supposed to treat that individual treatment. That's going to require our own education, our experience, our wisdom, and the circumstances that we are confronted with at that time. So we personalize the medicine. Now, so severe traumatic brain injury is some external injury that has happened, and usually it's the result of a moving vehicular accident, falls. It could be concussive injuries, blast injuries, and so forth. But most of these guidelines, most of what we're going to be talking about is how do we manage the secondary injuries that occur as a result of that impact. And those secondary injuries begin at the moment of the trauma itself. They occur at a macroscopic and microscopic level. And while the primary injury itself, of course, is quite significant, the way in which we can improve the outcome will be based upon how we manage the secondary injuries. And that's what these guidelines are really all about. So they're the issues of hypotension, hypoxemia, metabolic disturbances, increased intracranial pressure, seizures, you name it. All of these are factors, secondary injuries, that are going to be involved in allowing us to help a patient who has had a severe traumatic brain injury. And these are some examples of what those are going to look like. You can have so there can be an extradural hematoma with that little lenticular type of configuration. There can be the parenchymal hemorrhages as a result of the trauma, usually along with subarachnoid hemorrhage. There can be the diffuse axonal injuries. There can be the acute subdural hematomas. There can be a combination, including intraventricular blood and subarachnoid hemorrhage, which is very common. And then there can be this pattern, which is this very severe diffuse injury in which the ventricular system is effectively lost. And the earlier one sees that, the more pessimistic one is about the outcome. Now, I do in my research gene therapy, and we could do an awful lot to prevent traumatic brain injury if we could just edit out stupidity from the genome. So much of what happens, it's somebody my age up on a ladder cleaning leaves off of the roof with no common sense whatever. So stupidity is probably the single biggest cause of traumatic brain injury, and if we could edit that gene, we would be able to save ourselves a lot of difficulty. But that being said, and because this was a guidelines, and I said stupidly, I said, oh, well, why don't I go and do the Brain Trauma Foundation guidelines, which are actually the standard set of documents that we use. And I will work through that at this presentation. And so that's actually what I have done. But when you begin to look at the guidelines, you realize there's a whole lot of smoke that is created in the study and the analysis of the guidelines, but actually very little fire in terms of true level 1 type recommendations that can be made. But we'll go through them, and where I can update them, I will try to update them so that you will have at least what currently is the type of information that we're working with. Now, in preparing the guidelines, this is a very large task involving lots of people reviewing lots of studies. And so to come up with a true level 1 type recommendation is difficult because usually the body of evidence is not sufficient for you to come up with that type of recommendation. This is just a list of the kinds of steps that are taken in trying to develop these guidelines. And the most recent, which was published at the end of 2016, is the 4th edition, and that involved 189 publications, of which only 5 had Class 1 evidence, 46 with Class 2 evidence, and 136 with Class 3 evidence, and 2 meta-analyses. Now, it's not because the people doing this don't want to use Class 1 evidence data, it's just that it doesn't exist. The studies are just not being done in a way that it can qualify for that level. And we'll see at the end of this talk how the Brain Trauma Foundation is changing their approach and entering into a consortium that will have institutions doing studies in a way that they will generate Class 1 data so that we can really get some level 1 recommendations about how we should be treating the severe traumatic brain injury. So the ratings that you will see are based upon whether it's a high confidence, a moderate confidence, or a low confidence in terms of the body of evidence that has been developed. This is not just one study. It's a whole compendium of studies for each subject that you want to examine. And you're trying to come up with a high confidence that the evidence is such that it will hold true for all future studies. In other words, that it is correct. Moderate levels of evidence suggest that changes will occur in those recommendations after some additional data has been provided. And of course, low confidence is actually the likelihood that there will be changes in those recommendations. You still have to treat the patients and you still have to decide what you're going to do, but we're trying to improve the level of confidence that we have in treating these patients. So level 1 recommendations are based upon high quality body of evidence. Level 2A recommendations are based on a moderate quality meaning that they may change over time. High quality meaning that they're not likely to change over time. And the level 2B and 3 is parsing between lower level body of evidence in which you either have direct or indirect evidence to support whatever conclusion you have drawn. So the 4th edition came up with with 11 treatments, 3 monitoring procedures, and 4 thresholds in terms of recommendations that were going to be made in the treatment of the traumatic brain injury. And the treatments that were looked at, this is the list of them, and we will quickly go through all of these. The monitoring that went into this study was intracranial pressure monitoring, cerebral perfusion, and advanced cerebral monitoring, which used to be, in the previous edition, brain tissue oxygenation. The thresholds are blood pressure, intracranial pressure, cerebral perfusion pressure, and advanced cerebral monitoring. The major changes in terms of the 3rd edition to the 4th edition are that there now is a recommendation about cerebral fluid drainage and about decompressive craniectomy. And the additional changes is some things have been removed. The discussion regarding intracranial pressure technology, that is the type of intracranial pressure monitor you use, was taken out because the group decided they really couldn't properly make a recommendation about that. Hyperventilation was changed to ventilation therapies, and brain oxygen monitoring was renamed to advanced cerebral monitoring. So I'm going to spend a little time on the decompressive craniotomy recommendations because it illustrates some of the problems we have with using the whole idea of guidelines. So if we look at decompressive craniotomy, now so this is decompressive craniotomy for trauma. So this is where intracranial pressure cannot be managed medically. And this has been an area of considerable controversy for all neurosurgeons over a long period of time as to when it is appropriate to do this. Of course, the level 1 evidence is, and you should not be surprised, and you will see this a lot for the rest of this talk, is that there is insufficient evidence to make a level 1 recommendation. A level 1 recommendation is where the quality of the body of evidence gives you a high degree of confidence that further research will not change that result. So why is this a dilemma? And it's because the recommendation, which was not at a level 1 but a level 2A, and was based on a study, the DECRA study, which is a randomized clinical trial of decompressive craniotomy, that study, which was the earlier study, did not show a benefit in outcomes at 6 months on the Gauss-E scale. And it was done in patients who had severe traumatic brain injury but without a mass lesion, and who had elevations of their ICP greater than 20 millimeters of mercury for more than 15 minutes. Those are some of the criteria. So if you did a bifrontal decompressive craniotomy for a severe traumatic brain injury patient, the outcome was no better than medical management, and thus the recommendation was not to do it. However, a lot of people didn't believe this, so we went on to a further study. Well, the other recommendations from the decompressive craniotomy, which reached a level of a 2A, was, and this we all knew, was that when you did a decompressive craniotomy, you did have an easier time managing the intracranial pressure. So if your endpoint was, I want to make my intracranial pressure management easier, then do a decompressive craniotomy. But if the endpoint was, I want the patients to do better, then you had no supporting evidence for that. And another level 2A, which means a moderate degree of confidence in the evidence, is that a large decompressive craniotomy would be better than a small decompressive craniotomy. So those were the positive end results, but the major outcome or recommendation was that if a better outcome was your goal, this would not provide it. So the rescue study, which just was reported out a short time after the fourth edition of the brain trauma group, actually did show that there was a decreased mortality with the decompressive craniotomy, but there were several things that were different about the study in that they included a hemicraniotomy as well as a bifrontal craniotomy. And the end result was that some of the individuals who had a relatively poor initial score did improve. And they thought that that was clear evidence that decompressive craniotomy actually would work. However, the problem with that study was that they set the bars differently in terms of what they rated favorable and unfavorable on the Glasgow outcome scale. And when they did that, they actually ended up showing it. But if you used the same criteria as you used on the earlier study, there was no benefit. So the Brain Tumor Foundation could not make a recommendation on the basis of what was some of the preliminary results coming out of rescue. And still to this day, it's going to be hard to make a high confidence recommendation. So in the other areas of treatment is hyperosmolar therapy. You might be surprised to know that there is no good data on something that we use every day. But if you try to study the data, there is no specific recommendation on hyperosmolar therapy, though we know that hyperosmolar therapy, either using mannitol or salts, will decrease the intracranial pressure. It's just that the studies they're not there to give you, the body of evidence is not sufficient to give you a recommendation that you can actually state, even though we know this is exactly what we do. This is our own treatment at the University of Massachusetts, which is if our target is 60 milligrams of mercury, we use either mannitol, and there's variability whether people like hypertonic salt, which one is better, and so forth. And I'm going to talk more about these things tomorrow at the ENLS course. But the point being that even though we use these things every day to treat patients, we don't have a recommendation available for us as to what we should be using and how it should be used. If we look at cerebrospinal fluid drainage, which is where you place an EVD, an extraventricular drain, this was added. Again, the level 1 evidence, even level 2 evidence is insufficient. It just has not been studied in a manner that can provide a high level of confidence. But we know at a level 3 level that that continuous drainage is helpful in managing intracranial pressure and can be considered. The ventilation therapies, basically the recommendation was that it's not recommended to use hyperventilation to control intracranial pressure. In analgesics, in the use of analgesics, there was no level 1 or 2A data regarding the use of these medications. But we know we use them. We use barbiturates to manage intracranial pressure that is otherwise refractory. And there's a whole new area that just has not come into the guidelines methodology yet regarding sympathetic or paroxysmal sympathetic storms, things that might have significant clinical outcome, but the data just is not there to make a specific recommendation. Steroids, maybe the only level 1 recommendation that exists, which is that steroids play no role in the management of traumatic brain injury. Nutrition, again, no level 1 evidence, but there is some developing evidence regarding the appropriate way to manage nutrition in a traumatic brain injury. Infection in the same way, no level 1 evidence. but there is a reasonably moderate level of confidence about the role that tracheostomy might play in the use of antibiotics. In deep vein thrombosis, again, only level 3 evidence. And in terms of what you might use, whether it's low molecular weight heparin or a mechanical device that's used to protect. Seizure prophylaxis, again, the level 2A evidence is that seizure prevention for the first 7 days, or that the use of an anticonvulsant in the first 7 days can be warranted. There's some evidence to support that. That long-term use of anticonvulsants is not supported, and that using the anticonvulsant does not actually alter outcome. When we look at the monitoring, this is a series of recommendations regarding monitoring. In ICP, this is still a debated point. There is no level 1 evidence that supports intracranial pressure monitoring. There is certainly evidence at a level 2B that ICP monitoring will reduce the in-hospital stay and the 2 weeks post-injury mortality. And then we go through, this is a change from the 3rd edition, which actually found that there were certain conditions in which ICP monitoring was appropriate, and that has been withdrawn based upon a reanalysis of the available data. In other words, using more stringent criteria, they said that the body of evidence wasn't sufficient to justify that. Cerebral perfusion monitoring, again, at a level of 2B, there is, it can be recommended that you can use this and that it may have an impact on mortality. On advanced cerebral monitoring, which in our case, we're usually talking about the use of brain tissue oxygenation. There's no data to support that at this time, but we are looking for results now of the BOOST trial, which is now into a BOOST 3 phase, and it's just starting up. And that will be a very well designed study that might eventually show that using advanced monitoring, in this case brain tissue oxygenation, is important. Again, these were the recommendations for intracranial pressure thresholds. There's, again, no level 1 or 2A evidence. This varies from whether it should be 20, 22, or 25. In cerebral perfusion monitoring, there's a level 2B recommendation to stay between 60 and 70 millimeters as your cerebral perfusion pressure threshold, to not go above that. In advanced cerebral monitoring, once again, we're looking for the results of the BOOST 3 trial, which is really just beginning, so it's going to be several years before we're going to be able to have that result. Though currently, this is our standard of practice. So the conclusions are, and this is what the Brain Tumor Foundation is doing, is that we're moving from a published document every 7 years or so. In fact, that the 4th edition is considered the last published document, and that everything else will be a living guideline. That is, changes will be made as the data comes forth. There will not be a wait for the 5th edition. It will not happen. And the second thing is that they've entered into this brain tumor evidence-based consortium, and the purpose of this is to get groups working together to design studies that will actually answer questions that are necessary to treat our patients better. And we're looking forward to that as a new road toward developing true level 1 recommendations. And I thank you for that. Okay. Intracranial pressure monitoring is indicated for which of the following patients? You should come to tomorrow's lecture for the answer. Oh, wow. Everybody's good. Okay, that is correct. It doesn't really apply to any of these other situations. So very good. Next one. One more. Which of the following findings is consistent with possible herniation? Okay.
I request Dr. Panchavak to felicitate Dr. Richard Moser, please. Thank you. Thank you, sir.